Hello, everyone. Thank you all for joining today. It's my pleasure to welcome you to this PQI Innovation webinar titled Labor and Birth in People with Excess Adiposity, Implications for Clinical Care. My name is Kaylee Vitek, and I will be operating the Zoom logistics of this webinar and introducing today's speakers. When I'm not providing tech support for PQI, I'm a project manager for the Massachusetts State Perinatal Quality Collaborative. A couple of housekeeping items before I introduce our speakers. This webinar is being recorded and will be posted for free on the PQI website. There will be time for Q&A at the end of the presentation, so please type any questions you have into the chat and we will address them during that time. If you experience any technical issues, please send me a private message and I'll do my best to help. Now it's my pleasure to introduce today's speakers. Renee Byfield is the program director, co-author, national faculty, and a birth equity coach with the Institute for Perinatal Quality Improvement, PQI. Dr. Deborah Bingham is the CEO and founder of PQI. And our keynote speaker for today is Nicole S. Carlson. Nicole is a tenured associate professor at Emory University School of Nursing. At Emory, Dr. Carlson conducts research on the biologic mechanisms of labor and strategies for achieving optimal perinatal outcomes and decreasing racial disparities in birthing people with different levels of adiposity. She has received support for her research from the National Institutes of Health, the March of Dimes, and the American College of Nurse-Midwives, and was awarded Best Research Article and Podium by ACNM and JMWH several times over the past 10 years. She is currently PI of an R01 investigation titled The Weight of It All, Balancing the Scales for Pregnancy and Birth in Black Women, a 5-year prospective observational study to better understand how the social determinants of health, structural racism, the midwifery model of care, and pregnancy lifestyle affect prenatal metabolic health and labor birth outcomes. This work is made possible by the amazing group of community members, students, midwives, nurses, faculty, and staff who are part of the R01 study team. And now I will turn it over to Dr. Bingham. So thank you for listening and enjoy the webinar.
Good morning, everyone. It's so great to be with you today and to just give you a quick update about what's going on at PQI. Just to remind you is the PQI's mission is to expand the use of improvement science in order to eliminate preventable perinatal morbidity and mortality and to eliminate perinatal racial and ethnic disparities. We have a lot of work to do. As you can see, this is a map of the United States showing mortality rates, infant mortality rates across the country. And there is a huge amount of disparities across the state due to the inequities in the type of care that is provided and options for infant care. We also can see there is these racial disparities. As you can see, is that American Indian and Alaska Native, and also Black non-Hispanic infants and Native Hawaiian or other Pacific Islander non-Hispanic are the populations of infants who are more likely to experience infant mortality. In addition, we have seen a rise in pregnancy-related mortality over several years with a spike due to the COVID pandemic in 2020. And so this is very concerning. We have seen that there is also this timing of death is also happening during pregnancy and on the day of delivery accounts for about 36% of all of the deaths, with other deaths occurring postpartum. We have racial disparities in pregnancy-related mortalities as well, with, again, non-Hispanic Black women and non-Hispanic American Indian or Alaska Native people also experiencing the highest rates of pregnancy-related deaths. This is extremely concerning to us because we know that over 80% of these deaths are preventable. And I know I've given a lot of information really quickly, but let's just pause and let that sink in. That 80% of these deaths are preventable This is why we're doing what we're doing. And again, there's a disproportional burden of these deaths based on someone's race and ethnicity. We've also seen almost a 200% increase in severe maternal morbidity. What we're doing at PQI about this is one of the programs we have developed is the Speak Up Against Racism program, because as I just pointed out, how one fares in the United States has been characterized by a racial division that begins at birth with disparities in healthcare. We are proud to say that we are now have 1,793 Speak Up champions across the United States, and we hope to have even more Speak Up champions and would love to have you become a Speak Up champion. And you may wonder, how do I do that? Well, on November 15th and 22nd, we're having our next Speak Up Champion course. It is an 8-hour course spread over 2 different dates, and we would love to have you join us and attend that course. In addition, we have an action plan, a learning pathway where you can, we outline all the things that Speak Up Champions are in the steps 1, 2, and 3, which includes the 8-hour course. And those that become champion are then able to also become ambassadors and then be eligible to apply to become faculty in the program. We're very, very pleased to announce we have 2 cohorts of Speak Up faculty that are national faculty that are also available to help spread this important program. And if you haven't known our results, we have data showing the effectiveness of the program, and Renee and I presented on this in our September webinar, and there is a recording of that presentation. We have Speak Up modules, so if people are unable to attend the 8-hour course, there are online modules that are also available for people to be able to access. And we also offer for free a 28-day anti-racism challenge, and this will begin in February, but we recommend that you register now, just get the registration in. And it's really an amazing way to learn more information. Once you register, starting in February, you will be given daily emails that include reflections and learning activities, and then an action. And so you can join us for the whole 28 days or as many as you can participate in during that month. We're also very pleased this year. We also released the Birth Equity Modules course. This course has 4 modules. Module 1 is about creating an anti-racism statement. Module 2 is about improving data collection and data review by race ethnicity. Module 3 is a birth equity module on how to perform team and family debriefs from a racial equity lens. And module 4 is a birth equity module on ensuring perinatal care standards are met for birth equity. So a few other things we have in addition to our Speak Up program is that these free webinars that we offer, and we have a whole series of recorded webinars that you can access. In addition, I'm proud to say that the book that I am co-editor of, and this is a book written by my son who died in unfortunate, tragic, preventable death. Me and a couple of his colleagues from Boston University were able to edit this book, and it is coming out in December. And here we want to make sure you have the promotional code and know how to access it. If you want to learn more about social determinants of health, social factors and structures of health, this is a really great book for that purpose. In addition, we have our intermittent auscultation course. Because of the high rates of severe maternal morbidity, we believe very strongly that reduction, the data show us, it's not just a belief, but the data show us that if we support physiologic birth, that will help us reduce C-sections, which is a lead driver of severe maternal morbidity. And in addition, we are expanding the skills in quality improvement. And this course is coming up next week. And wait, not next week, the week after. And there's still time to register to participate if you want to get some additional skills in quality improvement. And now, without further ado, I am going to turn the time over to our esteemed speaker, Dr. Nicole Carlson.
Great. Thanks so much, Deborah. I learned a lot there, and definitely interested in the QI Essentials Conference. As we'll talk about at the end of this talk, I have some specific suggestions for any of you who are clinicians or working with clinicians to be able to enact some of the lessons that I'll share with you that I've gotten from the research in a QI projects. So, all right, Deborah, you go on and share the screen with the slides. So welcome everyone, and so happy to have you here. So we're going to be talking about labor and birth in people with excess adiposity, and we'll get into this optimal clinical care piece. Okay, next slide, please. All right, so objectives for this talk. First, we're going to be talking about current estimates of excess adiposity in pregnancy in the US population. I see in the registrations that we have people from all over the United States, so we'll give you some idea of what it looks like in your state as well as across the United States. Also, we're going to be talking about then how excess adiposity during pregnancy affects the labor and birth processes and how it can affect the response that that person might have to common labor interventions. And then finally, we're going to apply this understanding of physiology in pregnancy to how can we take better care of patients with excess adiposity to optimize their intrapartum outcomes. And I'm going to be focusing on intrapartum outcomes. There's a lot of things that we should be doing for antepartum and postpartum, but those are different talks. All right, next slide. So just some acknowledgments. This is some funding that we've received from NIH and also collaboration with other researchers to present some of the data I'm going to share with you today. No conflicts of interest to report. Next slide. Okay, so first, a little explanation of terms. You're going to hear me talk about adiposity, and usually the first question I get is, well, what do you mean by that? And how does that relate to BMI? Next slide. So what we know is that BMI has only limited usefulness as a predictor of what we call lipotoxicity. So what is lipotoxicity? Any of you who have ever done a workup or had a diagnosis for metabolic syndrome, you know what lipotoxicity is. It's basically the same thing. It's basically where there is a maldistribution of the way that the adipose tissue is being overloaded, and it starts to have a cascade effect on the body that can increase the cholesterol, that can cause insulin resistance, fatty liver. These are all part of that same constellation. So we know that BMI is somewhat predictive of who will and who won't have lipotoxicity. But for any of you who have ever done a 1-hour glucose test on someone whose BMI was 18 and it came out 145, you know that not necessarily, you can't look at someone and measure their weight and height and necessarily know who's going to have a problem. So what we know in specifics is that roughly about 30% of people who have a quote unquote normal weight BMI actually do have metabolic syndrome or lipotoxicity. And by contrast, roughly 30% of people who are in these quote unquote obese BMI ranges actually have a healthy metabolism. So this discrepancy between BMI and adiposity is worst in Black females. And so where the research is going is that we suspect that other measurements will take the place of BMI in coming years, and in some fields they already are. So for example, body fat percentage is probably better at measuring BMI adiposity. And so we have data coming from our study and others that will hopefully get us more along the road to getting a substitute for BMI. Next slide. Okay, so, and you'll notice I'm going to use the word excess adiposity rather than obesity, because as I mentioned, not only is it not a great capturing of what's going on physiologically, but also the word obesity can be very triggering for folks, and there's been actually a lot of qualitative work that's looked at for people who are in higher BMI groups, how would they prefer to be referred to, and almost never is it obese. So in my own practice and in my research, I'm really trying to move away from that. However, you will hear me use the word obese in this when I'm directly giving you the results of studies where they used the regular classifications by BMI of obesity. Next slide. Okay, so however you want to qualify it, we do see that the BMI pre-pregnancy BMIs have been going up over time. So this is, you can see data from 2016 to 2019. This is the entire United States. And they've split people by self-identified race, ethnicity. And you can see that if it maybe is non-Hispanic Black people are at the very top, but and then Hispanic total and non-Hispanic white are at the bottom. So as I mentioned, non-Hispanic Black people are not as well captured in terms of BMI, in terms of adiposity, but even if it's not captured perfectly, you can see that it's going up, and it's going up for all groups. So any of you who are in clinical practice see this every day. That definitely the epidemic of excess adiposity is definitely here and getting worse in the patients we care for. Next slide. However, it's not equally distributed across the United States. So here you can see each state. This is the average for pre-pregnancy BMI in that state for people who start care in that state. So where you want to be is in the, and how it's changed. You can see the averages at the bottom. Average in 2016 was 26.1, and then 2019 it had gone to 29. So you can see the colors correspond to whether or not it's no significant change, which there's only one state at the top, Vermont, where there was no significant change from that time. But you can see that in most cases, the change was in the green zone, which is a 10 to 13, or in the Arkansas has specifically had a much higher change. So the situation, unfortunately, is getting worse almost the entire United States, but we do see variation from state to state in how quickly it's getting worse, which leads us to understand that this is not something about humans. This is something about their lived circumstances. Next. Okay, and the problem in pregnancy is that when we have a situation of excess maternal adiposity, we know that there is a variety of adverse health outcomes, both for the birthing person and for the newborn. And you can see them listed here. Not a surprise to anyone who's in clinical care. Next slide. And some of these things are modifiable. In other words, we can do something about it with better clinical care. So I'm going to focus here on the intrapartum process, and specifically focusing in on what happens in terms of how long labor lasts and the interventions that we do or don't do during labor, and how those can impact our outcomes. And the biggest outcome I'm really going to be focused on is cesarean birth. Next slide. All right, so one of the biggest things that happens when we have excess adiposity is that labor gets longer. So we have both epidemiologic and clinical evidence supporting that there's what we call a dose response slowing. So that means for each increase in a person's BMI, we see a proportionate slowing of the process of labor. And so as many of you know who are in clinical practice, one of the number one reason why we do a cesarean birth in this country, 60% of the reason why we do cesareans in this country, doesn't have anything to do with the health of the mother or the fetus. It has all to do with that labor is going too slow. We call this labor dystocia. Failure to progress. There's different words that are used, in our nomenclature, but it all refers to the same thing, which is there's labor's going more slowly than we think it should go, and it's that what we think it should be that is the problem in people with obesity, because they're being compared to someone who doesn't have excess adiposity, and when in fact they should have a totally different timeline that we're functioning under. So this graph here you can see is a basic part graph. Time is on the bottom, dilation, cervical dilation is on the y-axis, and you can see that for all these different colors correspond to different BMI ranges for the mother. And you can see that as you go up all the way to that brown line, that the lines get kind of drawn out. It's corresponding to this increased time that someone's taking to get from 4 to 10 centimeters. And so because of this slowing, we see that there's a 5% increase in the risk for unplanned cesarean for each 1 point increase in BMI. So that's a pretty big difference that we see. Next slide. So to get into a little bit more granular detail on this is from the same study that I just showed you the figure from on the previous slide. And so what they've done here is that they're looking at cervical dilation, and you can see the columns at the top correspond to different BMI ranges. They also looked at second stage with and without an epidural. So what I want to draw your attention to is the numbers inside the cells for first the BMIs less than 25. You can see for those people to get to 4 to 10 centimeters, the median amount of time it takes is 5.4 hours. But the interesting number is in parentheses, 18.2 hours. That is the 95% longest duration. And so when we're talking about clinical care, it's nice if someone has, kind of a nice average labor or median amount of labor duration, then that's a celebration for that person. But really where our care centers around is when we get into this 95%. So we want to see what is the length of labor that is still within normal limits, but is longer, and how long is too long. And so this 95% longest duration is in these studies is really that demarcation line for this has gone on past the point of where the 95th percent of people would have already made this change. So you can see that for someone whose BMI is less than 25, that's 18.2 hours. Whereas you can see over here on the right, for someone whose BMI is greater than or equal to 40, that is 25.6 hours. So that's almost a 7-hour difference in how long it takes to get to 4 to 10 centimeters. And this is for nulliparous people. And on the next slide, I'll show you the same information for people who have had a baby before multips. You can see 17.5 hours to get from 4 to 2 centimeters if their BMI is less than 25. And if you look over, it's 20.6 hours for greater than or equal to 40. So not as big of a difference, not a 7-hour difference. It's more like a 3-hour difference, but still labor is going more slowly. Next slide. And so what I'm going to review with you now are some studies that we did to look at, well, okay, so if this labor is going to be slower, how can we better take care of people during labor to try to protect them from unnecessary cesareans? So this was a study that I did about 10 years ago. It was at a single hospital, the University of Colorado. The really interesting thing that made this hospital perfect for this study was that they had a labor and delivery unit that covered 2 floors. There was an OB floor and a floor that was really midwife groups. It was a midwife-led model of care, for those of you who know what that looks like. And so what we did was we looked at nulliparous people who were term singleton fetus, vertex presenting, whose BMI was greater than or equal to 30, who had spontaneous labor onset. So those of you who are researchers or clinicians know this is the lowest risk people except for their BMI being over 30. And we looked at the labor interventions and outcomes, including unplanned cesarean birth for the OB floors versus the midwife floors for these healthy people with obesity. Next slide. And what we saw is what I would term the domino effect, which is something that people often see where after we have the onset of the first kind of labor intervention to try to speed labor up, there's often a succession of interventions that take place after that, often culminating in cesarean birth that happens. So what we saw is that on the midwife floor, there was people, once they came into the hospital, were given more time to try to make some cervical change before oxytocin would be started. So oxytocin obviously is something to speed up labor. These people were in spontaneous labor. And an aside note for you to understand how this hospital particularly worked is that they had a single triage unit for the 2 floors, and it was staffed by the same group of midwives. So really no one got onto the OB or the midwife floor until they were 4 centimeters for spontaneous labor. So they were basically, you could say, starting from the same place in labor once they were admitted to the hospital. And then, but the interesting thing is that what happened after that. So in the figure that you can see here, this is a histogram, which means that we're getting a count of how many people on the OB floors are the blue lines, and on the midwife floor is the green lines. And you can see the kind of how high the bar is how many people were started on oxytocin augmentation for their labor at any particular hour. So basically what you can just notice sitting back and looking at this is that there's a frame shift where the blue lines corresponding to the doctors are starting Pitocin on people sooner than the midwives are starting it. And in fact, it was about 2 hours earlier that the OBs were starting compared to the midwives. And so what were the midwives doing during this time? Well, they were doing things like hydrotherapy and ambulation, intermittent auscultation. And remember, these were low-risk people except for their BMI. And so they were eligible for these protocols. And what it meant for the patients on the midwife floors was that since they were doing these other interventions, it gave their bodies some extra time to start to make some change in their labor so that they ended up not needing oxytocin. It was about there was about a 60% reduction in the oxytocin use on the midwife floors as a result. Next slide. And in this same caregiving environment, we did several other studies where we looked at what else was true for these patients. We saw that there was a 87% less operative vaginal births on the midwife floor. And as a caveat to this, I will say that anyone who got an operative vaginal birth on the midwife floor, we counted for the midwives. So still 87% decrease. We saw 76% less 3rd and 4th degree perinatal lacerations. And when we looked at the whole hospital data set, we saw that the midwife clients had about a 50% lower rate of unplanned cesarean birth. So there's some benefit to doing this, these other types of interventions. I call them complex labor interventions, like ambulation and allow, letting people have hydrotherapy options that really can make a difference for people being able to get through their labor into a vaginal birth. Next slide. Okay, so here I wanted to also address what happens during induced labor. The last study I told you about really focused on people with spontaneous labor. Well, as you might expect, induction is, of course, a lot longer than spontaneous labor in anyone. And in people with higher BMI ranges, it also takes a lot longer. So here's a study from, you can see it was over 15,000 nulliparous people where they looked at the time from admission for the induction to the start of active phase. And then they looked at the time from active phase labor into when the birth happened. And you can see the rows correspond here to the BMI ranges. And just scrolling down the median for the time from admission to the start of active phase, you can see that the median time does increase as the BMI goes up from 12.9 all the way to 26 hours. And again, looking at here, they didn't give us the 95%, but they did give us the 75%. So this is where you want to look for how long is, really most people have made the change at this point. You can see there's about a 10-hour delay for people whose BMI is greater than 40 compared to people whose BMI is less than 18. And so, and that's for the time to get to active phase. Once we get to active phase, you can see similarly over here on the right side, there is an increase in the amount of time it takes. And if we add these two times up, for people in the 18, normal range BMIs, that it takes about 36 hours for them to get from labor admission to birth. and that is increased for people with BMI greater than or equal to 40 to 46.9 hours. So a big difference, 10 hours difference. If you think of that's a whole shift in a hospital, that people with higher BMIs need extra time during a labor induction. Next slide, please. So now I'm going to break down for you some of the things that we've figured out through the literature that can make a difference. And this isn't just for people with excess adiposity, really probably, and in fact, the studies show that even in an overweight range of BMI, we see some of this labor going more slowly. So these are really things that should be applied to everyone, but especially if your patient has an excess adiposity. So first, a latent phase of labor during induction. This is not something that is really being talked of a lot in clinical circles, but it's definitely being covered in the research world. So this was a study that Groveman was the PI. Those of you who are familiar with the ARRIVE trial, he was the PI of the ARRIVE trial. They looked at people getting induced. As you can see, they had almost 11,000 people, term nulliparous people, and they were across the United States. They found, and the purpose of the study was to look at how long of a latent phase is normal and can result in a safe vaginal birth. So this is, they defining latent phase as happening after cervical ripening is complete. And I'm going to tell you the Bishop scores for what they considered that to be. After the bag of water has been ruptured or is ruptured on its own, and after oxytocin has been initiated, but prior to 5 centimeter cervical dilation. So really we're talking about probably someone moving from maybe 3 or 4 centimeters to 5 centimeters during a labor induction process. And they found that greater than 40% of people in that study had an 18-hour latent phase, still with a safe vaginal birth. So from this, they're recommending that we wait at least 15 hours for this latent phase to complete before thinking about a cesarean for failed induction of labor. This study did not take BMI into account, so we can kind of assume that it would be even longer on a latent phase for people with excess adiposity, maybe closer to that 18-hour line. Next slide. Okay, so let's talk about this cervical ripening and when should we consider that to be complete and how to do it best. Next slide. Okay, so what we know is that birthing people with excess adiposity are less likely to respond to prostaglandins for cervical ripening. They're less likely to reach active labor when these agents are used, and they typically are going to need longer to get to birth after using these. Next slide. And there specifically appears to be, in some studies, a problem with dinoprostone as opposed to misoprostol. So exogenous PGE2 or dinoprostone may not be as effective as PGE1 analogs, that's misoprostol, for labor induction. In a study in 2015, they found that you can see the success rates for misoprostol are 78%, Cervidil 66%. These findings weren't seen in a 2020 study where they didn't really see a difference, but in a more recent RCT, so the gold standard of clinical evidence, and it was a small study, it's 164 nulliparous people, all with a BMI greater than 30. They actually found that cervical catheters compared to dinoprostone were far superior. There was a difference of 25 hours in the duration of their induction. They also, patients with the cervical catheters had lower rates of tachycystole with the catheter. So the takeaway is that when you're doing a labor induction with someone with a higher BMI, you really want to try to use cervical catheters if possible. If you can't get a cervical catheter in, you can use a prostaglandin to help you get to the point where you can, but really to try to move as quickly as possible to a cervical catheter. Next slide, please. Okay, so now in some settings, there's been some good evidence to suggest that combining prostaglandins with cervical catheters is helpful. There's been a recent study, 2021 study, where they looked at this in people with excess adiposity. Again, this is all nulliparous people with a BMI of 30 or greater. It was a multi-site RCT. they compared people who were being induced with a Foley catheter plus PG1 versus PG1 alone. And next, and keep push the button again. There you go. And so they found that there was no difference. So it didn't make things go faster. It also wasn't unsafe, but it didn't make things go faster. So, you know, the combining methods that we sometimes see to be very effective in people without excess adiposity might not be something we can count on with people with higher BMIs. So other tips that I just wanted to throw in here, if you are using transcervical catheters at your institutions, higher filling volumes are definitely known to result in quicker labors. And the transition from latent to active phase with a transcervical catheter looks very different than it does with prostaglandins. Typically, you don't see active phase starting after a catheter until 6 centimeters versus 4 centimeters with cervical ripening caused by prostaglandin. So giving people that extra time to make that transition afterwards is really important, especially if their BMI is higher. Next slide, please. Okay, so I just wanted to bring in this outpatient cervical ripening outcomes. Can you hit the button one more time, Deborah? So what you can see here is that they compared people with BMIs greater than 30 who had inpatient versus outpatient cervical ripening. So obviously these are people who met the cervical ripening protocols. You can see that there were significant differences in terms of the time it took from the time of their hospital admission to birth, which makes sense. It would have been shorter in the outpatient group. They also found that people had a higher BMI Bishop score when they were admitted to the hospital. That also makes sense and is good. And then one more hit of the button to go. Yeah. So they also found that a lower C-section rate, 19% C-section rate versus 44% C-section rate in the inpatient cervical ripening group. So if your institution already offers an outpatient protocol, this is something to really look at whether or not people with BMIs greater than 30 who are otherwise healthy are eligible for that protocol. And if they're not, to really try to advocate that they be. Next slide, please. So when to stop cervical ripening, just if there are nulliparous, we should really be doing cervical ripening until the bishop is 8 or more. And if they're multips, bishops of 6 or more. Unfortunately, I'm seeing that a lot of places don't calculate bishop scores during labor inductions. And that is really a disservice, especially when someone has higher BMIs. Next slide, please. So let's talk a little bit about amniotomy. Next slide, please. And this could be during induction or during a spontaneous labor. We often use amniotomy to try to speed labor up. So this was a study in 2015 where they used electrouterine myography, and you can see this is what it looks like. It's these little blue stickers. Basically, they're measuring the uterus's electrical activity. And so they did a very simple study where they had people on these monitors, and then they broke their bag of water. And they found that women with a cervix greater than 4 centimeters, their uterus really activated after that AROM, like they could see more activity. Whereas when their cervix was less than 4 centimeters at the time of AROM, there was no difference in uterine activity. So the takeaway here is if you're trying to break someone's bag of water with the intention of trying to strengthen their labor, really try to avoid doing it until after 4 centimeters. Really scary kind of study, similarly methods found that as BMI increases, the uterine response to AROM decreases more and more and more. So, you know, I think especially if their BMI is higher, you're not necessarily going to see the big jump in kind of the pace of labor, the strength of labor after an AROM. Next slide, please. So we talked about waiting until at least 4 centimeters, especially in someone with excess adiposity. There was a recent study that I include here where they looked at people with a BMI of 40 or greater, and they were looking at early amniotomy, and they defined that as less than 4 centimeters to see whether or not that was associated with cesarean birth. And they found that it doubled their risk for cesarean birth for those early amniotomy. So they did a sub-analysis that to look at if this was true for all nulliparous people and multips the same, and they found that indeed there was a difference. that a lot of this increase in cesarean happened in people who were having their first, so nulliparous people. So if you're taking care of someone who's a nulliparous and their BMI is greater than 40, it's especially important to try to put off amniotomy until after 4 centimeters. Next slide, please. So there was another small trial where they compared early amniotomy within 2 hours after removing the Foley compared to delaying it to after 4 hours after Foley. And they found that early amniotomy was a shorter time to labor, a higher rate of birth in 36 hours, no difference in cesarean birth rate, maternal infection, or neonatal outcomes. So typically with a Foley catheter or Cook's catheter, when they're coming out, someone is about 4 centimeters dilated. So it's not known how this might be affecting people with a higher BMI, but I think the takeaway is here to try to wait until they're past 4 centimeters, and then within the next 2 hours after that is a good time to do the amniotomy. Next slide, please. Okay, let's talk a little bit about oxytocin use. Next slide. Okay, so in the figure to the top, you can see BMI category and total time. These are different studies that were included in a systematic review that our group did. And you can see that the total time people in need on oxytocin to get to birth and the total dose does increase with increasing BMIs. The multiple studies have shown this. This actually might have something to do with the path, like what's going on with slow labor in general, and not specifically with how that person with higher BMI is responding to the oxytocin. It may just mean that they need more time, period. But whether or not, we don't know all the underlying mechanisms by which this is true, but we can say for sure that you're probably going to have to get to higher doses and higher durations on oxytocin to get to birth in people with excess adiposity. Next slide, please. Another one, and this is recent data that we did with Dr. Kissler out of she's in University of Colorado. We did a secondary analysis looking at MVUs, and what we found is that MVUs have minimal usefulness in people whose BMI is 30 or above. This is a small study, and we need to do some further investigation of it, but for example, we found that only 13% of the people in the sample who all had a vaginal birth had an MVU that was equal to or greater than 200 prior to the final 2 hours of labor. So 200, those of you know, we're using MVUs to decide when to do a C-section for quote unquote inadequate labor. We also found that MVUs are minimally responsive to oxytocin infusions in these people, as well as not associated with labor progression, not associated with birth rate. So we should not be using 200 MVUs, or we should at least question the use of them as a threshold for quote unquote adequate uterine activity in people with higher BMI ranges. Next slide, please. Okay, next slide. So last thing I want to leave you with is a recent study that we did looking at how a person's size and the color of their skin or the way they appear to be changing people's risk for unplanned cesarean birth. So we looked at participant identified presenting race. So basically people's response to the question of how do other people in the United States identify and treat you? Obviously, sometimes the person's ancestry or their self-identified race or ethnicity isn't the same as the way they are seen by other people. But really, this self-identified presenting race allows us to examine racism as a variable. So we looked at that and we compared people with different presenting race or ethnicities on the primary outcome of unplanned cesarean birth in a large data set from the NIH. This is a multi-site study in the United States. Next slide, please. And we found some disturbing trends that have been replicated in other studies, that healthy birthing people in this data set perceived as white had about half the odds of unplanned cesarean birth compared to people who are Black or Latinx presenting. And the biggest indication for cesarean that differentiated these groups was fetal intolerance of labor. We also found that maternal morbidity was highest in groups of people who presented as BIPOC, especially if they had low social support or had recently moved to the United States and didn't have, weren't fluent English speakers. Next slide, please. So this gives you a quick peek at what was going on. So what you can see, the different colors here, and you can see along the bottom, we have people grouped according to their BMI from quote unquote normal weight to obese category 3. And the different colors of columns refer to their presenting race. So you can see that the blue bars refer to people who are Black presenting. Notice what happens as you go up in the BMI categories. As you would expect, the C-section rate goes up. These bars are higher as you go from normal to overweight to obese 1, 2, and 3. But notice that the blue bars are the highest, and they continue to go up the highest. So what we saw here when we did the statistical analysis is that Black presenting people in larger bodies had the highest risk for unplanned cesarean. They were higher than white or Hispanic people, even in similar sized bodies. So there's something going on here at this intersection of a bigger body and a body that is presenting as Black, where we feel like we have the greatest problem in our healthcare systems with not giving people the same opportunities for vaginal birth. Next slide, please. Okay, so clinical pearls, things to look at. Next slide. Okay, so this is a busy slide, but we'll go through it together. So here's the key takeaways for you. The first is when you're taking care of people with excess adiposity, to be patient. As we talked about, it can take up to 7 hours longer for their labor to happen from 4 to 10 centimeters. So we want to think about using these complex labor interventions like ambulation or hydrotherapy, doula care, especially if their BMI is greater than 39.99. We want to try to avoid hospital admission until active labor. In this group of people, that might not happen until over 6 centimeters or around 6 centimeters. And so with the use of labor lounges, other types of facilities perhaps also could be useful. During a labor induction, we know that it's going to take a lot longer, around 13 hours longer for the person with excess adiposity to get to birth compared to similar people with lower BMIs. And we really want to focus on this latent phase of labor, both during spontaneous and induced labor, but we now know more about needing to wait these 15 hours after cervical ripening, after rupture membrane, after the oxytocin was started, after all of that's finished, and before 5 centimeters, giving someone 15 hours and that to get that latent phase done before we start to expect to see a little more quicker pace of cervical change. We want to try to avoid AROM until at least 4 centimeters in people with excess adiposity, knowing that it doesn't have the same effect on uterine activation. And this is especially true if they're nulliparous. Outpatient cervical ripening is safer, faster, and increases the chance for vaginal birth, especially in people with excess adiposity. So if your institution doesn't have it, trying to figure out if you could get it. MVUs are not helpful measures of uterine strength, so using them to try to differentiate who needs a C-section based upon their progress, it would be more accurate to go back to some of these tables that I've showed you and look at the 95% or the 75% median time for people in that particular BMI category. Oxytocin may need to dose for longer periods of time and possibly at higher titrations. And then finally, this variation that we see by provider and hospital and geographic area, especially in the management of category 2 fetal heart rate trations or non-reactive fetal heart rate, may allow for these intersectional biases of maternal size and race to occur. So if your hospital doesn't have a standardized protocol for measuring these category 2 fetal heart rate traces or category 3 fetal heart rate trations, but especially category 2, which is, as any of you have taken fetal monitoring know, is where the majority of tracings are, and it can be the haziest kind of place in terms of how we take care of people optimally in that range. Next slide, please. So If you aren't already doing this, see about trying to calculate your practice or unit cesarean birth rate. Also, try to, for each patient, tracking their maternal BMI, and just doing some simple statistics to see what is the difference by BMI on the cesarean birth rate. You want to collect information also on the clinical indication for these cesareans. So not just whether or not they had one, but was it for fetal heart rate problems or an arrest of labor? Was it planned? Was there an arrest of descent? Do you see differences by the indication for people in different BMI groups? Do you see differences by maternal race? Or in both of these things, do you see differences? Next question. Another idea for QI intervention would be to use these evidence-based timelines for labor progress, individualized by maternal BMI. I've given you references here to pull those 95%. So, and then look at, like, you could even put this into your clinical charts, you know, in your figuring out, okay, for each person at a C-section, how long did their labor last prior to that cesarean? And was that shorter than maybe how long we should have waited optimally before we called that cesarean? Looking for those types of things can perhaps reveal some really interesting things for improvement in your place. Next slide. We could also recommend documenting the appropriate BMIs reached before switching from cervical ripon to oxytocin in your labor inductions. So having that be another thing for each patient that you care for, at what Bishop score were they switched to oxytocin? And perhaps this is probably one of the things I see making the biggest difference in the successful induction rates, especially in people with excess maternal adiposity, is making sure we get to these Bishop score cut points before we're switching over. Next slide. We want to think about supportive care during the latent phase. So recommend that a latent phase be observed, as we talked about, of at least 15 hours. And during spontaneous labor, use of hydrotherapy or ambulation in latent phase, especially prior to 6 to 7 centimeters. These could also be used during induction, especially if you have wireless monitors. Next slide, please. We want to think about trying to track when we're doing AROM at what cervical dilation, and seeing, especially for people whose BMI is greater than 30, if we're successfully trying to delay that until after 4 centimeters or beyond, rather than doing it too early. And we want to look at the use of category 2 fetal heart rate response algorithms prior to calling a C-section. So if your institution doesn't have an algorithm they already use, I've given you reference here, one from CMQCC as one example. There are others. The most dangerous situation is if you're in a place where there is no algorithm. People are just, individual providers are managing these situations where the fetal heart rate is perhaps a little concerning, differently from provider to provider. That's where bias comes in. Next slide. All right, so that's it for me. I wanted to recognize all of the amazing people who helped to make this work possible, including my mentor at the top, Nancy Lowe. And also you'll notice the picture here on the bottom of Renee Byfield, who you heard about earlier. Renee is working, in addition to everything else she does, she's also very integral to our project. Next slide, please. Here are 2 articles that, if you're specifically interested in the information that I shared about labor induction, our group, we did a review of evidence-based methods for successful labor induction that was published in JMWH. And we also did the new clinical bulletin from ACNM on induction of labor. So those are 2 specific references that I would, you could probably get a lot more information in there, including about quality improvement opportunities. Next slide, please. And then here's some selected references from some of everything that we've just gone through. Okay, that's it for me. So got a few minutes here for questions.
Thank you so much, Dr. Carlson. So much wonderful information, very helpful to for clinical practice. And there is, I know we have a few minutes. There is a question. Can I move forward with our questions, or did you have any last thoughts before we move into the question segment?
Oh, go for it, Renee.
All right, wonderful. So Kara says, is there data on PPH and higher BMI people who are having longer labors or
Say that
induction
again, the
labor?
first part.
Is there data on PPH and higher BMI people
Oh,
who are
yeah.
having longer labors or induction of labor?
Yeah, great question. So, as you would expect, the longer that the labor induction lasts, the higher a person's risk for hemorrhage. That's no different for anybody. There have been some conflicting evidence of whether or not there is an independent risk factor for hemorrhage for someone with higher BMI ranges. And the best we can figure right now, the kind of the preponderance of evidence is that it doesn't appear that BMI has an independent effect on that. It's just that, if your labor induction lasts 3 days, as it more often will happen to do in someone whose BMI is higher, then there are going to be more hemorrhages. Great question.
Thank you so much. And then we have one more. Jody's asking, when the studies talk about BMI, is that pre-pregnant BMI or the BMI when presenting for labor?
That's a great question. And I didn't get into this, but it's usually they're talking about the BMI that the person has when they're presenting for labor, which um, for a lot of people that seems counterintuitive because obviously the weight of someone at the time they're presenting for labor is what includes the weight of the baby, includes the weight of the placenta, the et cetera, et cetera. But it does, I think, give you it's even more alarming than what we kind of think of in terms of pre-pregnancy BMI that a BMI, say, over 30 in someone who is, term pregnancy, they have a slower labor. There's been some studies where they compared people who started, say, someone who started pre-pregnancy BMI of over 30 to another person whose pre-pregnancy BMI, say, was only 23, but the person who started out kind of in a normal range category gained excess weight compared to the person whose BMI was higher. What happens in labor? Is there an advantage, in other words, of more recently gained weight versus someone who's maybe had a higher BMI for longer? And they have found that no, indeed, their labors look the same according to whatever BMI it is that they are when they go into labor. It's basically the current metabolite, situation for them is what determines their labor length, not how long they've had a high BMI, if that makes sense.
Thank you very much for that. And one last question. How can I initiate the process of collecting adiposity statistics by race and ethnicity related to interventions such as cesarean rates and possibly other interventions? Like, where should I begin?
Yeah, it's a great question. I feel like what I see a lot is that most, clinical practices, they do a great job of collecting their clinical statistics. Most hospitals too. That's something you can pull from the EMR, but they typically don't collect the information to compare their statistics. So, for example, they'll have C-section rate on everybody. Did they have a C-section or not? But they won't necessarily have collected race or BMI at the time of labor. And so that makes it so that they can only look in their statistics at their overall C-section rate, not at their C-section rate in these different subgroups. If you're doing an optimal job with your clinical care, what you should see is that it's taking longer and longer for people with higher BMI ranges to get to a vaginal birth, but that they're getting there just as frequently as the people in the lower BMI ranges in most of the cases. So that's what optimal looks like. So once you're collecting statistics with enough detail that you can actually compare these ranges in your institution or in your practice, then you can really start to zero in on what are things we could do to allow more time to use the right kind of interventions to try to encourage those numbers to get better and better.
Thank you so much, Dr. Carlson. And we're actually at the top of the hour. Thank you so much for all that wonderful information, and thank you all for attending. Deborah, did you want to close out, or did you have any last thoughts?
Well, we have 1 minute left, and there was a question about athletes with high muscle mass. Are they at risk for the same issues? And can you answer that quickly?
No, they are not. They are not. It's a great question. And it's really where this body fat percent comes in. So athletes that are at higher BMI ranges look like they are quote unquote obese according to the typical BMI calculators, but they are not at the same risk.
Thank you so much. Thank you everyone for joining, and we'll see you all around next time. Thank you, Dr.
Thank you.
Carlson.
Thank you, Dr. Carlson. Have a wonderful day, everyone.
Thank you.